In this video, I'll be talking about the pathologic Q wave. And the reason I'm calling it pathologic is because we obviously see a Q wave in a normal EKG. And then there is a pathologic Q wave which we see during MI. So before we understand pathologic Q wave, we first have to understand what exactly is the normal Q wave. And then we'll talk about pathologic Q wave. So let's get right into it. So almost all of you are familiar with the normal QRS complex. This would be our Q, this would be our R, this would be our S. The Q is a negative deflection, the R wave is a positive deflection, and an S wave is a negative deflection as well. Now this is what I want you to remember. The Q wave is the first downward wave of the QRS complex, okay? It's the first downward displacement of the QRS complex. You might be wondering at this point is that, don't I know that? It is the first downward displacement of the QRS complex. Why am I putting so much stress in it? The reason I'm putting so much stress in it is because sometimes, in fact, most of the times, you might not even see a Q wave or a first downward displacement of the QRS complex. You might end up seeing something like this a lot of the times, okay? Q wave often does not show. So, and that's not pathologic, that's normal. So, in this kind of scenario, is this the Q wave? Is this the R wave? Where is the S wave? What would be your thought in it? What exactly are we looking at here? Now, this is what you have to remember. If there is any upward deflection in a QRS complex that appears before your Q wave, it's not a Q wave, okay? So by convention, this would be an R wave, the positive deflection, and this would be an S wave. And the Q wave we can't really see in this particular EKG. Okay, so what about if the EKG looks like this? After a P wave, this is all you see. What is going to be this wave? Is it going to be, well, we know that both Q wave and S wave have negative deflection. What kind of wave is this one? So for this particular wave, it is a little confusing, right? I mean, we don't know which one is which. So, I mean, we have two negative deflections, Q wave and an S wave. Therefore, this kind of wave is called a QS wave, okay? And if you are looking for a Q wave, then you take this as a Q wave. If you're looking for a S wave, you take this as an S wave. S wave, okay? So, depending on what you're looking for, you use it to your advantage. If you're looking for a Q wave, this is what you interpret. If you're looking for a S wave, this is what you interpret in a QS wave. So now that we have a little bit of understanding what a normal Q wave looks like, what would be a pathologic Q wave look like? So in a pathologic Q wave, usually what happens is the Q wave is relatively quite large, okay? Usually Q waves are so small that sometimes you can't even see it. It's a first deflection in the negative direction. But if the Q wave is really, really large, if the first negative deflection is really, really large, then you are talking about a pathologic Q wave. Now the Q wave is often going to be accompanied by an ST segment elevation. And usually we see a pathologic Q wave in case of an MI. Now here's a question for you. Do we see Q wave as soon as we have MI? Is it the first thing that is going to be evident on an EKG when a person is going through MI? Absolutely not. In fact, Q wave develops later. It usually takes several hours to days for a Q wave to develop. Often, Q wave is the proof of an earlier MI. So you might be looking at an EKG for a person who's completely healthy now, but you look at a Q wave and you can tell that this person had an MI in the past. It just means that there is a gap or a hole in electrical activity in that part of the heart which got damaged during an earlier MI. Now, does this mean that we are not going to see Q wave in an acute MI? No, that is not true. We will see Q wave in an acute MI, but really the first thing we're going to see is ST segment elevation, and a couple of hours later, 6 to 8 hours later, then we're going to be starting to see a Q wave formation. Now, my next question to you is, once a person develops Q wave, does it ever go away from the EKG? Well, let's say you have a patient who's going through an MI and the person developed Q wave, but you get to catch it early on. You reperfuse the patient, and the patient does not have that much damage to the electrical activity of the heart, and you can get rid of that Q wave. Yes, so it is possible to get rid of the Q wave if you reperfuse the patient very, very early on in the MI. But for most cases, once you have a Q wave, if the damage is significant, then you're going to have that Q wave indefinitely, showing you that there has been an MI, and it's just showing lack of electrical activity in terms of a scar tissue. So when the electrical activity is passing through the scar tissue, it's not showing that negative deflection. It just means that there is no electrical activity in that part of the heart. Okay, so we're looking at an EKG strip. Now, before we interpret this, I just want to say that we're going to start off with, a normal P wave, Q, R, S, and then T wave, right? This is the normal one. When a person is going through an acute MI, the first thing we're going to see is our ST segment is going to be elevated like that, okay? And then eventually we're going to start seeing Q wave and an ST segment elevation. Okay, so this is a typical acute MI. First, we are going to see the ST segment elevation. That's the first thing we're going to see in an EKG, and then after 6 to 7 to 8 hours, we're going to start seeing a Q wave along with an ST segment elevation. Okay, so let's see if we can recognize this in an actual EKG. So the first thing that jumps to me from this EKG strip is that, okay, look, PQRST, PQRST, these are pretty nice over here. But as we move to these lids, we can see that Q wave, Q wave, big Q wave, okay? So this is where it's quite obvious that these are pathologic Q waves, because we don't even see, R and S, or T wave, anything like that. Kind of here though, we start to see that there is a ST segment elevation over here, right over here. So that tells us that this is not a old MI. This is a recent MI, because we're starting to see ST segment elevation as well. Another picture of EKG, and this one is a lot more obvious because we can see Q wave here. And look how beautifully we can see an ST segment elevation. I know there's nothing beautiful about a ST segment elevation because the person is going through a lot of pain, but I mean, for our understanding, for our purpose of education, this is a very beautiful Q wave followed by an ST segment elevation picture to understand our pathologic Q wave. Okay, so let's look at another example. So we're going to be looking for a Q wave followed by an ST segment elevation. So we can see here that this is more of a Q wave, ST segment elevation, Q wave, ST segment elevation. Same here, Q wave, ST segment elevation, Q wave, ST segment elevation. We also see the same thing in lead AVF. We see a Q wave followed by an ST segment elevation. Now we're not considering these because we can see PQRS normally. So these ones doesn't qualify. We only look at the ones where we have a Q wave followed by an ST segment elevation. So in this EKG, this is again a huge picture of a Q wave and an ST segment elevation. There is no substitute for examples, right? So we could never get sick of it. So now that we kind of understand what Q wave and ST segment elevation looks like, now let's see if we can interpret EKG a little bit more. So we know that 1, 2, 3, AVR, AVL, and AVF, those leads are the limb leads, right? And then V1 to V6, those are the chest leads. So we can see here that in our chest leads, it's quite obvious. We have Q wave, ST segment elevation, 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 and the same here. The chest leads are showing obvious signs of Q wave and ST segment elevation. This is a beautiful diagram. Now, even in limb leads, we can see Q wave, a little bit of ST segment elevation here, right? This is a diagrammatic picture. This is not a real EKG, so that's why things are so strikingly obvious. We can even see it here, Q wave, ST segment elevation a little bit. So it's easier to interpret these than real EKGs. Okay, so now let's look at this EKG. We see that we are starting to see Q wave here. So lead 2, lead 3, again in lead 2, okay? Anywhere else we see Q wave? That's pretty much it. But it's not followed by an ST segment elevation. So this is a typical example of an old infarct. We see the Q wave because of lack of electrical activity there, but really there is no ST segment elevation. So don't be alarmed if you see it in a patient who walks in for a regular checkup. They're just having a normal Q wave from an old infarct, because once you have a Q wave, it will never go away unless you perfuse them immediately. Okay, again, let's look at another ECG. We see that, do we see any Q wave here? By the way, what are these? These definitely looks like Q waves, right? But they're not. Why? Why are these not Q waves? Because what did I say? Q wave was the first negative deflection. Sometimes we don't even see Q wave. We don't really see Q wave here. This is R, this is really S wave. So don't get confused whenever you see a negative deflection. Q wave has to be the first negative deflection. So, is there any Q wave in this picture or in this ECG at all? Yes, we do. Look at this lead, lead 3. What is lead 3? These are one of the limb leads, right? Look, the Q wave is almost as big as the R wave. And it should not be this way, because the Q wave should be really small. But this one here, we can see that the negative deflection is as big as the positive deflection. So this is definitely a Q wave here. This is an old infarct again. I'm showing you old infarct and new infarct so that you can pick it up faster. Again, we see a Q wave just as big as our R wave. And where else do we see it? We see it here as well. The Q wave is quite big, showing that this is an old infarct because this is not followed by an ST segment elevation. The big Q wave kind of starts from lead 2, so we can see a significant drop here, right? Because this is an ECG where the pictures are kind of small and Q waves are really, really small. So we start seeing it from lead 2, but it becomes really big in lead 3 and AVF. It's quite big and prominent in this ECG. So this is our last example for our Q wave. We can see that lead 2, they're starting to build our Q wave. Lead 3, whoa, look at how big these Q waves are. Again, an old infarct. And we should also see that in AVF. So whenever we're looking for Q wave, I usually look at 2, 3, and AVF. But we also see Q waves in other portions, depending on where exactly the infarct is. In this particular video, I'm only talking about how we can recognize a Q wave. In the subsequent videos, I'll be talking about, okay, when we see a certain Q wave in a certain lead, we have to determine where exactly the infarct is in the heart. But let's take one step at a time. In this video, we can see that the Q waves are building up in 2, more in 3, and we can also see that in a V.